Okay, so I'm gonna fill in a couple gaps that we have here. There was one week I was sick, and then we had a holiday this past week. Um, Fortunately, we had covered enough of the chapters, and I had filled in the gaps with that poster video. So I do suggest having the poster video out while we go over this. We're mainly going over the thyroid system. As far as the adrenal glands, that's where I have tabs where we haven't covered, and then Monday we'll finish up with our it's mainly the pancreas and stuff that's very familiar but is very important as well. I am going to not do this video just face wise. Just I'm not feeling really great, but I really need to get the video out, and I do apologize that it has taken me this long. I've been not feeling great, so I'm gonna go ahead. I'm gonna share my screen. I'm gonna pause and then share my screen and just have you look at some picture. I'm gonna keep this short and sweet because you do have your poster, you have other, you have your book, of course, you did your assignments, but I do think that there are some important nursing points to make, and I want to make sure that everybody is prepared for their quiz that's opening up tomorrow, which you will be. And there's only a few other things I'm probably going to add. I have I think 5 questions left that I need to put on the test, which is good. That's good news. So pretty much the study guide is done. The study guide is more of a I didn't like this word, but you're welcome. So even though it's not done, I'm doing my very, very best, and I'll probably add a few more things tomorrow. I'm just not. I need to get a little bit of rest, but I do want to post this. So let me go ahead and I'm going to pause, share the screen, and then I will talk about the thyroid and the adrenal gland. So give me just one moment, please. Okay, so for those of you who want to follow along in your book, we're on page 798, and we're basically going to page 812. So on a lot of it, as you know, I mean, there's a lot of pictures and stuff like that. So it sounds like a lot more material than it really is, but it is important material. So we're going to go ahead and start on page 798 if you'd like to follow along. And we're just going to kind of start out with, and again, if you have that poster that I made, that I think is such a valuable tool. That's just my opinion. Again, it depends on how you learn. I'm all types of learning, but I really like this visual because this is a pretty complicated system, the endocrine system. So I'm going to start at the bottom here where it talks about patient education. Or wait, I think we started, yeah. So we're on the thyroid at this point. We ended there, just double checking, sorry. Yes, we did. Okay, so we are starting with patient teaching at the bottom of page 798. And it's talking about patient education, and I believe there was a question like this on the quiz, just about the importance of really, if you have your thyroid taken out or hyperthyroidism, the importance of taking your medication in order for, as you all had seen on the poster and through other lectures, how important that the endocrine system is, that it works together. So if your thyroid gland is not getting the hormones that it needs, a lot of different things are going to happen, such as our first topic would be hyperthyroidism. So hyperthyroidism has to do with hyper, obviously, of course, meaning too much. So that means that we have too much thyroid gland. I'm sorry, that we have too much thyroid hormone, and it could be for multiple different reasons, as you can see on your poster, because it's not just your thyroid that is creating and excreting. Well, it's the one that's actually excreting the hormone, but it's not necessarily the one that is in control of it. And I think that's the biggest takeaway here. And the reason I'm saying that is because if you had a patient that were to go into the doctor's office and they're having issues and they're describing their symptoms to you, you may think, this sounds potentially like their thyroid, something might be going on with their thyroid. Okay, great. That sounds good. Okay, we'll run some tests, but it might not be the thyroid in itself, because the thyroid is not the only thing that controls the thyroid, right? We have the hypothalamus and the pituitary gland that have something to do with the thyroid as well. So there's 3 different potential reasons why the thyroid hormones might be out of whack, if you will, and not being controlled the way they should be. And that's a really important thing to understand as a healthcare provider, and as obviously the physician would know, and being able to run the test and kind of catch the signs and symptoms of, brittle nail or whatever it is that you're diagnosing, depending on what part of the endocrine system it is. So for example, let's just take hypothyroidism, because that's the next topic in the book on this page, where it talks about, so there's primary and then there's secondary. So if it's primary, it makes sense, because if something has to do, with primary hypothyroidism, this is when it's actually occurring with the actual gland itself. It's the primary source. So that would mean that the thyroid itself is not doing what it would normally do on its own. It doesn't have to do with the pituitary gland, right? Because remember, the hypothalamus tells the pituitary gland what to do, and then the pituitary gland sends that message down and says, hey, thyroid, you need to do this. So that would be secondary if the pituitary gland wasn't working. So let me say that one more time. So if the pituitary gland was the one that basically was having the issue, if you will, and not speaking with the thyroid gland as it should, that would be considered secondary, because that's a secondary source, and that's why your thyroid's not working. It's primary if your thyroid gland on its own is not working. And I think that's an important thing to understand, because that's, of course, medical language. It's understanding the feedback mechanisms and understanding kind of how the connection really occurs. And just as a side note, that Graves' disease is caused by hyperthyroidism. So Graves' disease, I'm sure you've heard of or read about in the book. You may have done some practice NCLEX questions about it. That's the relation between the two. Graves' disease goes with hyperthyroidism. So linking those two together. Really, I don't want to, there's the thyroid. I personally believe we do talk about it a lot, because a lot of those in our society do have thyroid issues where they either have to have their thyroid removed, or there's a goiter going on, or medication like Synthroid, levothyroxine, same thing, has to be prescribed. So I'm not going to go into too much detail. I think the adrenal glands are the ones that are not talked about as much. But I do want to point out some of the highlights, if you will, about the pituitary. I'm sorry, about the thyroid gland. So of course we know that hyper means above. So you're going to basically have a higher level of, we've talked about this before, metabolism has a lot to do with your thyroid, right? So you're going to have basically an increase in your metabolic rate, which is going to do a lot of different things to the body. And that's when your patient's going to come in and say, when you're getting your history, okay, what brings you in today? And the patient's telling you, well, this is happening, that's happening, this is how I'm feeling. And based upon those signs and symptoms, that's where you're going to be able to help kind of hopefully be that investigator and narrow down potentially what could be happening. It may not be it, but you could hopefully get on the right track. One thing that always helps me remember, so whenever I think hyper, I think too much, and then I think exercise. So like you lose weight, right? So hyperthyroidism, you're going to be losing weight. That's the first thing I always think of. I don't know why. Again, you do your thing however it helps you. Then I think, well, if you're too thin because you're losing so much weight, you're cold. So you have heat intolerance, which is also another symptom. So weight loss and heat intolerance are both symptoms of hyperthyroidism. So those I've been using this for years and years and years and years, and it has stuck with me. Another thing would be an appetite increase might happen because you are losing weight and your body is, homeostasis, right? So increased appetite might happen because of the weight loss. Your body's trying to tell you, okay, we need you to get more food inside of your body. Because you are having this unfortunate kind of metabolic issue in general, we have to remember that it does also increase different receptor sites in the body. So just as a side note, think of and this is another way I remember it, think about like norepinephrine and epinephrine. And those are both things that speed things up, right? Because we're talking about metabolism. And again, it's about making those connections. And I think, okay, weight loss is that. Okay, I've got that down now. But then I think, okay, what could other things happen? If you have an increase of norepinephrine, what might you see in that patient? You might see nervousness, right? Because you have so much epinephrine or norepinephrine. It's like that fight or flight symptoms. So you're going to see those symptoms. What's it called when your heart beats fast? Tachycardia, tremors. I said nervousness, potentially palpitations because your heart is beating so fast. So these are all things in your body that you might see as signs and symptoms of hyperthyroidism. And hopefully the way I explained it is giving the reason why it's happening. I think if you know why, that's the best way to be able to remember. So I think that is the most important part as far as the signs and symptoms and what it is. The other thing is that people see, and this is important. I haven't actually never seen it myself, but it has to do with the sign of Graves' disease, because I mentioned earlier Graves' disease and hyperthyroidism, they go together. So of course, this is my topic because it has to do with psych. You might want to take a special extra thought on, sorry, someone's at my door. I apologize. Let me pause this video. I'm so sorry. Okay, sorry about that. Okay, so what I was gonna say is that this is pretty interesting, and we haven't talked about this yet. I'm sure you read it if you read the textbook. And this will actually be on your test. I'm gonna let you know that. So hopefully, so if you get it wrong, A, you didn't read, and B, you didn't watch this. I'm trying my best to give you, hints and guide you in the right direction, especially for things that are not normally seen. So like this is something that is more rare. So under the signs and symptoms, if you're looking under hyperthyroidism, where it starts to talk about where is it? Because I want to like point you to the right direction. Okay, so yeah, so under signs and symptoms, in chapter 39 on page 799, it starts to talk about above where the gentleman has the eye, I can't say the actual word, where the eyes are bulging. It starts to talk about if treatment is not basically done or started for patients who are having signs and symptoms with patients with Graves' disease or hyperthyroidism in general, because I mean they kind of go together, that they can actually start to begin having psychotic symptoms. So that is something that is I will slide into the test to talk about, because that's important, because that could not so easily be missed. Somebody come in, and this is why we say we need to rule things out. If a patient comes in and they're acting psychotic or they're acting whatever, draw a blood panel for alcohol, do a drug test, check their thyroid. Thyroid is something that we actually, where I'm working, is something that we're really, really trying to do, because we want to rule things out. Maybe it's not necessarily psychological. It could be something like this, where we're talking about psychosis, or it could be something like depression, right? And that goes with hypothyroidism, but still, it could be something that we're trying to treat, but we're not treating what's needing to be treated. So that is really, really important. And it's a huge thing that, I mean, I know I've always really believed in, and as nurses, I want to teach you basically. So we'll move on here with, and this is on your study guide as well as remember, in your study guide, I tell you, look at your past quizzes, look at the past assignments, look at the past stuff that you've already turned in, because I do like to use that because I like the repetition. So looking at some of the complications in general. So for example, we have, thyroid crisis. I'm pretty sure that that is going to be on the test. I put there, I think, I don't know if I put thyroid crisis or thyroid storm, but that is something that it's a super um, concerning state that can happen when you're when you have, sorry, I'm not feeling well. When you have a thyroid storm, you have such a severe bout of hyperthyroidism that that's happening where you're just not, you're being undertreated, if you will, and you can develop another illness or stressor due to that. So I guess if the example could be um, the more important example, and this is the one I want you to like hone in on, because this is the one you're going to really see in the hospital, is that when this does occur, it usually occurs after the thyroid surgery in patients who are having hyperthyroidism, and let's say their thyroid is taken out and they may not be ready for with the medication, and they don't take the medication, then you could potentially and more than likely see a crisis going on, and death can potentially happen with this. And that's thyroid crisis and thyroid storm, is when you're not properly prepared once you get your thyroid taken out, which is really not good. And really, in all fairness, should not happen. I mean, we should have a plan. We know what we're doing here. I mean, we've been doing this for years and years and years. So if this does happen, usually the first thing we're going to do is, obviously, I mean, if the person stops breathing, we're going to do all of the things to help, oxygen, IV fluids, get everything going. And then hopefully get enough IV fluid to help any deficits that are going on, and as I had mentioned, oxygen. And then one other potential thing that could happen, or what we should do, would be some tests. So we're going to want to look at different tests for the thyroid hormones. So we've talked about T3, we've talked about T4. In this case, calcitonin is not an issue. We're talking about just the thyroid, the T thyroid hormones in general. And so if you have high levels of these, either T3 or T4 are elevated, and then your TSH is low, as I said earlier, that's primary hypothyroidism, right? Because that means that your thyroid is not doing its job. And then it would be the other way around. If it was the TSH is low, that means the pituitary gland is not doing its job, because it's not releasing the signal to the thyroid to say, hey, do your job, get it together. I really want you to pay attention to the therapeutic measures, as far as when we're doing certain things like radioactive iodine. That is something that's very important. And sometimes they use that to take away part of the thyroid gland and not all of the thyroid gland, because then patients won't have to usually take as much medication. So, but there are, of course, special things that we have to do when we use anything that's radioactive, to help avoid any sort of issues with the patient themselves, with people that are caring for the patient. So I really want you to take a look at that. One of the questions on the quiz last time was flushing the toilet twice, but I put once. You have to flush it twice. If you put any sort of contaminant like vomit or urine in the toilet, because it's considered radioactive. So we want to make sure that we are not exposing anybody to that. And I want to see if there's one more thing I wanted to mention about that. Nope, I don't think there was. And this is, I mean, I'm not trying to be, I'm not shortcutting anything. It's really, at this point, I feel like we've really discussed a lot. There's been a lot of videos shown, pictures and whatnot. Like, I think a lot of this is already kind of understood. So I'm more kind of trying to fill in the blanks as far as like actual patient care, and maybe some stories that I've seen or heard, or anything that I think might be important. But again, I'm trying to hit the highlights, not what I want you to memorize. It's no, what I want you to remember. Just want to put that again in there. So let's see here. The next part I wanted to talk about, the data collection, we already did that. It's always important. That's why we ask patient questions. I mean, that again, we're trying to get to the nitty gritty of what's really, really, really going on. And on page 800, it just talks about everything we just talked about. It just goes into a little more detail and kind of like the whole nursing stuff that we do. So go ahead and read that. Patient education, we went over this a little bit on the quiz, I believe, or it's on the test. Either way, I'm going to talk about it now. Of course, we want to, teach patients to talk about any of potential symptoms if they notice that they're coming back, because dosages may need to be changed of their medication, they need to be actually go in and remove more of the thyroid or all of the thyroid, if it's hyper or hypo, depending on what's going on. And if they are taking medication for hypothyroidism, patients need to be educated. They need to know what to look for so that they can know their body, know what's going on, and then seek help as soon as possible. Because these can, they're not just uncomfortable, but these can be potentially, life-threatening things that are happening. So I don't want to spend too much time talking about the nursing care patients receiving radioactive iodine. It is important. Of course, it's going to be in your NCLEX, but I think I did a pretty good job of that in the last video with when we did the quiz. But I'll just say just a couple things just to kind of to stick in your head, if you will. So there's different types. A common one is usually given by mouth. So orally, just a dose of radioactive iodine. And it is a fairly high dose. And for the patient, and this is usually done with someone with thyroid cancer, and the patient will be in the hospital while it's going on, of course, because we want to limit the amount of people that are around the patient because they're radioactive. And we want to, like I said earlier, so people that are taking care of their urine or their vomit or any secretions, we always want to flush the toilet more than once. We don't want any of our pregnant caregivers going in there because the patient is considered radioactive, and we're just being safe. And just knowing all of those things and kind of taking those into consideration. The reading is really self-explanatory. It was just more of, I wanted to point out that what it means, like, okay, they can actually take radioactive medication, they can swallow it. I think a lot of people think it's through IV, and it is something that can be swallowed, and it can be done just in one large dose. So I wanted to mention that. The next thing I wanted to bring up has to do with a goiter. And I'm sure we've all heard of what a goiter is, and if you haven't seen one in real life, it's pretty interesting. I haven't seen many. I saw a few in nursing school, actually. I don't remember why. I don't know if we went to a clinic or what we did, but I think I've seen at least 2 or 3. And that, of course, is an enlargement of your thyroid gland, and we call it a goiter. And it's a pretty known verbiage. And if the thyroid gland does become larger, it can either be from a couple of different things. So it could be either from your TSH being increased, or sometimes it could happen due to an autoimmune process that occurs from Graves' disease. So it could be from either or. And also TSH in general, when it's elevated in response to, and again, this is why I wanted you to have your poster out. I think it's just easier. When TSH is elevated in response to low TH, iodine in general, deficiency, pregnancy, genetics, other reasons and other conditions, that can be a potential reason for why this could also happen. And when a goiter is caused by iodine deficiency, this could also have to do with just factors around the person, like where they're living, their environment, and that would be potential. I've never seen this. It's very rare. It's called what is it called? I think it's not epidemic, endemic, I think, goiter. And there are medications to treat it. So if there is a goiter taking place, the medication is, I can't pronounce it, but it's called goiterogens. I have that in my notes. So that's the classification, and that can help to treat the goiter. And also, just a quick note, a goiter can also be caused with hyperthyroidism. So it can be caused by either or. And I'm going to let you guys can all read this. I mean, this is all it's not a complicated reading. So I don't want to take up more time by you listening to something that is really pretty easy to understand if you read it. And of course, the diagnostic test, we're going to take T3, T4, we're going to check the levels. We're going to also take the TSH, because we want to know, is it primary, secondary, where's it coming from, what's happening, what's going on. And then we kind of just go from there based off that, and then with the treatment. And cancer of the thyroid gland, you can go ahead and read that one. It's pretty straightforward. A lot of the time the thyroid is removed. Depending on how bad it is, they'll do the radioactive stuff that we were talking about, and they can either do it at home. They can, but they can't be around people, or they'll do it or limited time, if you will, or they can be put in the hospital. So the other part, so now we talked about hyperthyroidism. We're going to go ahead and switch over now to hypoparathyroidism. So hypoparathyroidism has to do with, as we had mentioned, we have 4 little glands on the back of our thyroid, and they're called the parathyroid. And that has to do with our bones. We've talked about that. And basically, a decrease in your parathyroid hormone is going to cause a decrease in your bone being able to reabsorb calcium. So a decrease in calcium absorption could potentially, give me one second here, sorry.